Hello, I'm Dr. Deepak Verma, physician and diabetologist. Today we are discussing a case poorly controlled diabetes woman with GIT, genital tract infection. A 68-old woman returned to our clinic with follow-up after 3 months after initiation of empagliflozin 10 milligram per day for his diabetes. Her glucose level has improved, but she complained of vaginal pruritus and she is worried that she has a yeast infection or fungal infection. We diagnose vulvovaginal candidiasis in this patient and prescribe a single dose of fluconazole, 150 milligrams daily. After reviewing her laboratory results, we noticed that since starting empagliflozin, her HbA1c level has slightly improved from 8.9% to 8 to 2%, but is still not where we need to be. Her ESFRI is around 69. Basically, SGLT2, sodium glucose co-transporter inhibitor, are increasingly important oral medication now in the days of diabetes type 2, with their use climbing dramatically in recent years. They result in a broadly similar amount of glucose lowering compared with other oral agents, but can also reduce blood pressure and result in modest weight loss. In addition to their glucose lowering effect, large-scale clinical trials have demonstrated reduction in the cardiovascular and renal outcomes in high-risk group with type 2 diabetes, as well as benefit in patients with heart failure wherever or not they have type 2 diabetes. SGLT2 reduce hyperglycemia in patients with diabetes by increasing urinary excretion of glucose. This induced glycosuria, increase the risk of GIT, genital tract infections. On both clinical trial and observed studies demonstrate that it's around 2.5 to 6-fold increase in the genital infection in people using GLT as compared with the control. Development of genital mycotic or fungal infection is more common with SGLT2 inhibitor. Overall incidence in clinical trials of 4 to 6% compared to other oral hypoglycemic agents. Can discuss patient from persistent with treatment. A number of factors have been shown to be associated with risk of GI infections, genital tract infection in general population, in particularly females, and diabetes, especially when glycemic control is poor. Now, combination of SGLT2 inhibitor and DPP4 inhibitor offer a suitable component in strategy to achieve the target of HbA1c without increasing the risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infection associated with SGLT2 inhibitors has been reported with when DPP4 is added, perhaps because of better glucose control, although other possibility mechanisms remains to be investigated. In clinical practice, the risk of urinary tract infection may be barrier preventing patient from receiving or continuing potentially life-saving therapy. In addition to local hygiene consultation on how to prevent urinary tract infection, identify combination therapy that limit the risk of such interesting strategy. A putative mechanism whereas DPP4 may moderate SGLT2 associated urinary tract infection deserves some comments. By far the most straightforward explanation is that DPP4 and SGLT2 combination reduce glycemia and glycosuria more than SGLT alone, therefore resulting in the protection of glucose control. DPP4 activity is present with some yeast, molds, and bacteria, and its inhibits may directly modify microorganism function. Their high suspectivity and sophisticated hypothesis need to be tested experimentally. Thank you.